Yes, we performed a large phase 3 randomized study of intensive therapy in patients with acute myeloid leukemia over 60. And we studied a standard intensive induction and consolidation strategy, and we compared it to a slightly lower intensity drug with clofarabine. In our first reports, which we reported a couple years ago at ASH, we found that the intensive therapy was superior. And we made a number of important observations from that study about the importance of complete remission, the impact of MRD positive disease in remission, and even the role of allogeneic transplant for older adults in a prospective study. This abstract deals with a second randomization that was embedded in the E2906 trial. So patients who were in complete remission and had completed and recovered from 2 cycles of intensive consolidation chemotherapy were randomized 1-to-1 onto a maintenance treatment for a year versus observation. We picked a year because that was what our preliminary data was at the time, and the sponsors, the National Cancer Institute, wanted us to adhere to that. And so originally we had intended to have 172 patients, but because our original study, the parent protocol, had stopped early because of the survival changes, we didn't complete the accrual to the second randomization. So we had 70% accrual, we had 120 patients, and they were randomized 1-to-1 to observation versus an intervention with low-dose decitabine. So decitabine was given 3 consecutive days, 20 milligrams per meter squared, every 4 weeks for a year. Patients had to have adequate hematologic recovery, so there were some dose delays for some people. And then we looked at disease-free survival and overall survival afterwards. What we found, first of all, was that decitabine was generally well tolerated. We had some cytopenias, but no deaths. We had a 9% incidence of fever and neutropenia, but no major problems with it. And it had a significant impact on disease-free and overall survival. We had an unusual statistical design just because of the fact it was embedded in a large phase 3 study and the number of patients we had. But that design allowed for a one-sided p-value of 0.1 to be significant, and we met that endpoint on the multivariate analysis for disease-free survival and, importantly, for overall survival. So we believe it supports a definitive randomized study. We think it's a potential to be an important innovation in this setting. The patients who went on it tended to be the intermediate risk patients, and almost half of them were over the age of 70, so it reflects a real-life population who would get to that phase. But importantly, when we looked back at the FLT3-ITD status of patients, most did not have a FLT3 mutation or did not have a FLT3-ITD, and that group had a strong survival advantage of decitabine maintenance versus observation. So it suggests to us there's a group that we can target to really make a survival impact in that space or in that population. And we're planning to take it forward and to do this in a definitive study, although we think our results are very compelling, and possibly to look for alternate strategies, such as some of the new oral agents that are out there to try to capitalize on this. It's a great question. You know, acute myeloid leukemia, we give intensive therapies and get younger adults through it, and we think we cure a substantial number of them. But the median age of AML is 70 or higher. And so it really is a disease of older adults. The study was already selected for people who were fit enough for an intensive approach, so we know that's not for everybody. There's some people who aren't strong enough for that. We have data on comorbidities. We've not analyzed that in detail yet, but we also acknowledge that we had selected a more fit population, and on that basis we didn't really struggle, or let me say it differently. We didn't see difficulty of people getting on the decitabine. That being said, the median number of cycles was 6. They were eligible for up to 13 cycles over a year, every 4 weeks over a year. The median number was 6, partly because 5 patients never got it, even though they were randomized to that, and partly because we think patients were having some dose delays. So it's possible that a slightly lower dose would keep people on schedule. It's also possible that going beyond a year will help. But I think we're going to have to ask that in a prospective study. The major messages really are we think that there's an advantage of maintenance decitabine. We think it has to be definitively shown in a powered randomized phase 3 trial, but our results are compelling, particularly in the large intermediate risk population who are FLT3-ITD-negative. We think that's where it's most likely to have its impact.